speak about it. None other than Dr. Supriya. SRIGANESH is here. Supriya, over to you.
Thank you, Anurag sir, for having me present on this prestigious platform. I'm glad to be here, and the discussions have been so interesting. This is one of the scenarios in which having the machine feels like an excellent investment. This is the polar cataract, especially with a PC dehiscence. So flax and posteropolar cataract. So let's just talk about PPCs. We know that they're a type of developmental cataracts with a very distinct morphology, characterized by multiple concentric layers with a distinct onion peel appearance or discoid opacity, and this is how you see the posteropolar cataract with a pre-existing dehiscence. You have this particular shape, these two linear lines, when you know that there's a pre-existing dehiscence. There is the Daljit Singh classification of posteropolar cataracts, which makes it easy to clinically identify that, especially when you see these white dense spots, it's a diagnostic sign, or the Daljit Singh sign, of posterior capsule rupture or extreme thinning with posteropolar cataract. So it's very important to see this sign. Now, generally the incidence of PCR in routine cataract surgery is less than 1%, but with PPCs it ranges from 14 to as high as 12.6%. So that's a huge percentage of eyes that can have complications in your cataract surgery. Now, the surgical challenges, as we know, is the adherence of lenticular opacity to the thin and fragile posterior capsule, high risk of PCR during the surgery, hydrodissection is always avoided, and nuclear rotation is contraindicated. So all these things make surgery very, very challenging, and these patients are often young patients who want spectacle independence. So how do you deal with these patients, and how does flax come into play? Now, we know that Sir has already discussed the technology. I won't go into the details. It ionizes the tissue by producing photo disruption, basically. And the advantages of flax, as we've discussed, is a precise, accurate, reproducible result in regular cataracts, but also makes it much safer for posteropolar cataracts. You get a capsulorhexis, which is round, continuous, circular, which is the most important step in PPCs. It helps you also with the lens fragmentation, and as a note, AIOS2025 can really also help you visualize the PC properly. So just a note on AIOS2025, in our practice we always use the AIOS2025 preoperatively to check whether there is a PC dehiscence, but for all PPCs we advise flax preoperatively. Now, this is very interesting actually. One of the first case series which evaluated efficacy of flax in PPCs, Adler and Donaldson, they actually said that flax resulted in PCR in 2 patients with bilateral PPC, whereas conventional phaco did not in the fellow eye. And they suggested that conventional phaco is actually the preferred approach in PPC. And in that study, they used the catalyst, and they had adjusted for a 500 micron safety zone from the posterior capsule. But the authors opted to perform hydrodissection during flax. So you cannot do a hydrodissection even if you're doing flax. It's very important that you avoid hydrodissection in flax, and then further studies showed, Dr. Vasavda et al. Showed the technique of femtodelineation to create multiple demarcated layers or cylindrical layers to remove the endonucleus before reaching the posteropolar cataract. And in all the further studies, hydrodelineation was done even when flax was used. Dr. Tityal described the block by block emulsification, which is a preferred technique which I have also done recently, which is very easy to core out the cataract with these cylindrical pieces. Dr. Mahipal et al. Also have used the catalyst system, and they have an offset of 1000 microns from the posterior capsule to enable better penetration. So now this is a video of mine showing how exactly to make your flax settings for PPC. So you see here, this is the pattern that we choose, the cylinders with the pie cuts. So you have a 2 or 3 plane chop. I selected a 3 plane chop with pie cuts and select medium power. This is the lens AR system. We have the Z8, the lens AR, and we also previously had the catalyst system. This is the dice module, but I prefer the cylinder with pie cuts. So this is how you select all your settings. You can also have a posterior offset. Here you see the posterior clearance is 1 mm, that is 1000 microns from the posterior capsule. This is very important to keep an offset, and then you save all your changes, and this is what the docking looks like. Like sir said, it's a flat dock. So here, once the docking is done, you get Scheimpflug images. Scheimpflug camera scans the eye and you get images when the capsulotomy is being done. And here you can see the pattern. So you see these 3 pie cuts along with cylindrical cuts. So this is the capsulotomy being made, and this is how the fragmentation is done. And the posterior capsule from 1000 microns is completely avoided. Now during the surgery, again, we don't use the femto for the clear corneal incisions because it's much more efficient with the blades, and just remove it using, here a hydrodelineation is done. You see these bubbles are released. It's very important for the bubbles to be released, like KP sir was saying, because this itself can cause a high intralenticular pressure. Now here, see how I'm able to easily core out piece by piece by piece the central endonucleus. After doing the hydrodelineation, the entire endonucleus you don't need to chop. Usually without the flax, after hydrodelineation you need to go chop the nucleus. That again causes more movement and stress on the bags, but these small pieces you can even use the chopper or the dialer to kind of manipulate the pieces to come into the probe and slowly bring the pieces out without any manipulation of the cortical layer or the epinuclear layer as such. And here you get a good removal. So it's always important to inject viscoelastic while removing the probe, as we all know. Here I'm doing a viscodelineation technique while just gently trying to nudge away the epinuclear plate using visco, and then it very easily comes out. And once the epinucleus is removed, I thought this was actually a PC rupture because it had that classical shape, but it was just the cortex. So in such a case, in this particular case, I did not have a PC rupture. I was able to easily remove the cortex with bimanual IA and use a lens, but you see a beautiful capsulotomy and how easy the surgery is and stress-free for the surgeon when you have this technology with you. And again, it's very important, even if there is no PC dehiscence, to always use viscoelastic while coming out of the eye, because you're avoiding those AC fluctuations which can anyway cause, the PC is quite thin even if there is no dehiscence. So always use the visco, stabilize the AC, and then remove your instruments. I'm able to implant a premium IOL, a toric IOL in a case of PPC because this again was a young patient and who desired spectacle independence, at least for distance. So we're able to give our patients good results even in complex cases. So now this was an older video of Dr. Ganesh. This is when we had the catalyst system. So this is what the catalyst system looks like, and you see the offset from the posterior capsule. You can see here there is a clear pre-existing dehiscence. So the OCT shows you the pre-existing dehiscence. You make the capsulotomy and the nucleotomy here, and like we were discussing, these kind of cuts, the disadvantage is that the patient fixation is reduced. So on table you can give a subtenon block after doing these cases, after doing the flax for these cases, because the fixation also really matters in these patients. Now you can see here that removing the endonucleus is easy, but you're not always as lucky as getting away with an intact posterior capsule, because you see that in this patient there was a pre-existing dehiscence. So when that does happen, at least you're sure not to have a nucleus drop. You do have to do a limited anterior vitrectomy and manage the case this way. But even in case you need to implant a 3-piece lens, you have a perfect capsulotomy that you can implant the 3-piece lens in the sulcus and do a good optic capture. So after carefully removing all the cortical matter, 3-piece lens is implanted, and you can do an optic capture and have a good result even in patients with pre-existing dehiscence. That's a stable lens. Now, in the past, for pre-existing dehiscence patients, we were not able to offer the option of spectacle independence. But today we have excellent lenses like anterior capsulotomy fixated lenses where we actually are able to offer spectacle independence for patients with this kind of picture. So you see here there is a pre-existing dehiscence. The patient wants a trifocal lens, they want spectacle independence. So here you can just see that a good hydrodelineation is done. You can see here only the capsulotomy is done using the femto. Nucleotomy is not done because it's a very, very soft nucleus and it's just very easily aspirated with the phaco probe. And this is Dr. Ganesh's case, and you see here that he is just using the coaxial IA to very easily just remove the epinucleus as well, and to remove the PPC part he is using a bimanual IA because in these cases you get much better control by using a bimanual IA. You see that typical characteristic pre-existing dehiscence there, but the beauty of this is that there is no vitreous loss. Even if there is vitreous loss, you can do a limited anterior vitrectomy. The lens that is used here is the Femtis M Plus lens. So this lens is actually an anterior capsule fixated lens with 4 haptics. You see the clip there where you can actually clip it onto the anterior capsule. You inject the lens into the bag and you clip those 2 haptics onto the anterior capsule. It's a segmental varifocal lens which gives spectacle independence. So this, even though it's a plus 15 diopter lens, it's a young myope with a posterior polar cataract, we were actually able to give this patient uncorrected 6/6 and N6 vision in both eyes in spite of the pre-existing dehiscence. So the technology today actually allows us to give patients this kind of result. So in both eyes, this was the post-operative images. You can see in the left eye, it's a toric IOL as well, toric multifocal, and there is a PC dehiscence. So complex cases like this, we can still have excellent results by using flax in combination with these kind of lenses. And to conclude, I would like to say always approach a PPC assuming that there is a PC dehiscence. Advise flax for all your PPC patients. It's a much safer way to go. A gentle hydrodelineation is required. Just because you're doing flax, it doesn't mean you can do a hydrodissection. And it's shown excellent results in cases of PPC, making the surgery much safer and easier. And of course, a preoperative ASOCT and UBM imaging is always helpful. Thank you so much for your patient listening.
Invigorating, Supriya. Thank you so much for that.